In an emergency, simply pressing on a chest is not enough. There is a precise mechanical difference between going through the motions of CPR and actively pumping blood to a dying brain. Despite advances in medical science, survival rates for cardiac arrest remain suboptimal. Yet, when responders perfectly execute the American Heart Association's strict mechanical guidelines, a patient's probability of neurological recovery multiplies. Today, we are going to master the exact biomechanical steps required to turn your body into a highly efficient artificial heart, maximizing cardiac output during an adult resuscitation. Technical precision here is the sole determinant of whether oxygen-rich blood actually reaches the patient's brain and vital organs. Let's build the mechanics. Step 1 begins before you ever push on the chest. You must slide a rigid CPR backboard directly under the patient's torso. This diagram shows why. A standard hospital mattress absorbs up to 40% of your kinetic energy. A rigid backboard provides opposing resistance, ensuring your downward force translates entirely into the chest cavity. Next is your hand placement. Position the heel of your dominant hand precisely on the lower half of the patient's sternum, right between the nipples. Place your second hand on top and interlock your fingers. Pull those fingers slightly upward so they hover above the chest wall. If your fingers rest flat, you disperse the compression force away from the heart and significantly increase the risk of fracturing the patient's ribs. By combining the hard surface of the backboard with isolated pressure on the sternum, you ensure 100% of your physical effort is driven directly into the cardiac pump. Now, lean forward until your shoulders are positioned directly over your hands. This alignment creates a strictly vertical line of force. Lock your elbows completely. This diagram illustrates how locking the joints transforms arms from flexible limbs into rigid structural levers. If you bend your elbows, the joints act as shock absorbers. That vertical force line breaks, and compression energy bleeds away. With your arms locked, the engine for your movement shifts. Keep your upper body entirely stiff and hinge strictly at your hips and waist to generate the downward motion. Hinging at the hips utilizes the sheer weight of your torso. This prevents your arm and shoulder muscles from rapidly fatiguing over extended periods. Building this rigid skeletal lever and utilizing gravity is the only sustainable way to maintain high-quality compressions minute after minute. Once you have your lever built, you have to hit the targets. The American Heart Association requires a compression depth of 2 to 2.4 inches, delivered at a rate of 100 to 120 beats per minute. This chart shows coronary perfusion pressure. It takes 10 to 15 consecutive compressions to build enough pressure to push oxygenated blood into cardiac tissue. Between pushes, complete recoil creates a vacuum, drawing venous blood inward. Leaving residual weight stalls this vacuum, flatlining the pressure. Without that venous return refilling the chamber, your next compression is squeezing an empty heart. That results in zero cardiac output. The upward release of the chest is physiologically just as important as the downward push. Recoil is the only mechanism that refills the heart with blood. Even with perfect mechanics, silent fatigue sets in. To maintain continuity, the clinical protocol requires actively swapping the person performing compressions every 2 minutes. During these transitions, any hands-off period for rhythm analysis or securing an airway must remain strictly under 10 seconds. This feeds directly into chest compression fraction, which dictates that compressions must be actively occurring for greater than 80% of the total resuscitation timeline. If you pause for longer than 10 seconds, the coronary perfusion pressure you built up plummets instantly to zero. It will then require dozens of new compressions just to rebuild that lost baseline. Maintaining a high compression fraction through rapid, coordinated team swaps is the ultimate protector of the perfusion pressure generated by your physical compressions. When all of these precise biomechanical steps work in perfect unison, you establish a flawless, continuous rhythm. Let's review the final checklist. Rigid board placed, shoulders aligned, elbows completely locked, hip hinge engaged, full depth achieved, complete chest recoil. Executing this specific sequence of mechanics transforms a standard CPR attempt into maximum possible cardiac output. Through technical precision, your physical technique literally becomes the patient's heartbeat.